This is a very important subject, and probably it cuts across all the oncology practices, where we will be talking about communication while negotiating goals of care. So, my presentation would encompass the situations where the goals of care change. What do we understand by the choice of goals of care? How to do a goals of care planning? What are the various aspects of decision making and communicating when goals of care changes? And what are the various communication challenges when goals of care change? So, what are the various situations when goals of care change? So, there is what we call the trajectory of illness or the cancer journey, and we have transition points. There would be a diagnosis, then a treatment phase. Either patient will get better or controlled, a progression phase, more of symptoms, more and more dependency, decline, and end of life. So, this is what we call the journey of cancer. And at each transition point, the goal is different. The goal of managing these patients are different. The goal of care is different. So, what are the various situations? So, when the disease progresses, disease comes back, when the patient have serious complications, patients are unable to tolerate the treatment because of serious side effect, there's a difficult to control symptom, people have their own personal preferences, and there are various contextual choices. It could be finances, it could be logistics, it could be family. At all these situations, the goal is different. We all talk about choosing wisely, and we all talked in the morning about choosing wisely. There is a goal with in terms of disease centered metrics. So, disease centered metrics is not just the only one thing that determines the outcome of the cancer treatment. There's a whole spectrum of things, what we call person centered metrics. So, what I'm talking in negotiating goals of care are these person centered metrics. So, what are the various choices people come with? Most of them, of course, want a complete cure, and always it is not possible. So, if complete cure is not possible, what is the other option? The other option could be prolongation of life as much as we can, relief of pain and symptoms, improvement in quality of life, a good end of life care, and a support to the family. So, these are the various host of choices or the goals which people want to achieve. So, what are the challenges that are there? It is not a binary choice. Lot of time in our clinical practice we come with binary choice. Okay, either patients will get cured or nothing can happen, you go home. This is what we call a binary choices. Most of the hospitals, most of the doctors, most of the oncologists even now do binary choices. So what we are talking about is there need not be a binary choice. It can always have the multiple option. When the patient is getting a curative treatment, patient can also get relief of symptoms. Patient can also get psychological support, emotional support. All other aspects related to decision making can be taken care. So there are multiple goals that are running concurrently, and goals keep changing from one point to another, and there could be contradictory goals. So the person may want a treatment, at the same time also want limitation of some other treatment. So we have to take all this into the mix while we communicate and negotiate the goals of care. So basically I'm just giving a simple 3-point example. The first goal, if you are looking at, if cure is the goal, what would be our focus? Eradicate the disease, and the attitude is to fight. A patient would receive all form of treatment, all form of life sustaining treatment. But if it goes from curative to the next phase, that is life prolonging, your focus is control. I always say in oncology the 3 C's: cure, control, and the comfort. So that we go to the life prolonging thing. So your attitude is to fight. There the attitude was to cure, your attitude is fight. and maybe they may be treatment candidate for disease modifying treatment. However, it could change further, where it changes into more and more symptomatic or palliative treatment, where the attitude is to avoiding complication, avoiding harm, and symptom control, and the attitude is accept. So it was cure, means eradicate, it became fight, and now it's going on to an accept. And probably they may not be a candidate for all those disease modifying treatment or all those life sustaining treatment which they were candidate earlier. So basically what I want to say is, as so goals of care is not a static thing. It is not written in stone, or it is to be applied as it is. It keeps fluctuating. It is a dynamic phenomenon which changes along the trajectory of illness. So what are the components of goals of care planning? So in the entire morning that we had discussion today, and the entire last day, we all focused on only one goal, that is the disease management goals. So where you talk about the burden versus the benefit of treatment, how treatment changes or evolves, or when to institute a treatment or when to stop treatment. So this is what we call as the disease management goals. The other important goal is symptom management goal. What are the symptoms patients are experiencing? And symptoms need not be always physical symptom. It could be also the emotional issues. It could be also anxiety, depression, distress. So what are those symptom management goals? And how we can ensure adequate management of symptoms even when the patient is receiving treatment intended towards cure or for control. The third important goal is communication goals. A lot of times patients are distressed because they are not certain about what's happening. They have a very little information about their treatment or what is going to happen in the future. So they need to understand what's happening, and we need to elicit what would they like to know and how they can use that information to cope with their illness much better. Also, the next aspect of goals of care planning is decision making goals. Patients would like to make life decisions, isn't it? If it's a life changing event, cancer is a life changing event, and people would like to make those life decisions. So who makes the decision? Whether the patient is capable of making the decision. If the patient is not capable of making the decision, who else is participating in the decision? Is there a next of kin or a friend or a surrogate who makes the decision? Also, we have to look at what are the practical goals of this patient. The person may be employed in a place or may be running a business. What happens to that employment? What happens to that business? How this disease impacts that person's personal life, the practical things. What is the place that person would like to continue treatment? What are the logistics involved in caring that person? And also the most important thing is anticipatory goals. What happens in the future? What we can anticipate for that person to have, and how we should plan ahead for the future. There was a article that was published in New England Journal of Medicine where a patient came to the emergency room tattooed "Do not resuscitate," because that person was so scared that when he walks into the ER, somebody is going to do a CPR and resuscitate that person. So it's important to talk about what kind of treatment they would like to receive in the future. What is the nature of treatment? So that is the anticipatory goal. So just want to recap. There are 6 important parts of goals of care plan: the disease management goal, the symptom management goal, the communication goal, the decision making goal, the practical goals, and the anticipatory goal. So if you put all of them together, then only we can have a meaningful goals of care discussion. So there is a framework for having a goals of care discussion. The first thing is to know that whether the patient is ready for goals of care discussion. There's no point in having our agenda and thrusted upon the patient when the patient is not ready. The first thing to ensure readiness, and once you ensure readiness, you always have to balance the truth and the hope. You don't want to destroy the hope of the person, but at the same time, you do not want to give an unrealistic hope. So you need to have a very realistic hope that has to be there. So always elicit what are those personal goals, and then start making recommendation. Have a clear plan for the patient, and after you have this discussion, after you have a plan, please document that plan very clearly so that your colleagues understand the plan and everybody is on the same page. A lot of time only one person has a discussion and is not documented, and your other colleagues won't know what is the plan for that patient. So please follow the framework for goals of care discussion. So before communicating, always before we start talking about goals of care communication, we should know few things. The first and foremost thing is what is reasonable for the patient or the family to hope for, because they come with lots of hope, but you need to be certain with the changing technology, with the change in the cancer treatment, with advent of new cancer treatment, what is that realistic thing? What I might be thinking 5 years back about a cancer treatment is completely different now. So I myself have to have a full awareness about what is realistic for that patient to expect, and what is the realistic goal here. You should be knowing what is that realistic goal. The patient family may say that the realistic goal may be a complete cure, but you know that is not the realistic goal. So you need to understand what is the realistic goal and what is reasonable for the patient and family to expect, and should there be setting of limits. So many times I have seen some of my medical oncologists, because the patients ask, because the family asks. I have heard what is called as a chemotherapy on compassionate grounds, because they say that because the patients have asked, the families have asked, we are giving. But should there be a setting of limit? Should we consider the benefit versus the harm, or the benefit versus the burden? Is there coherence between trajectory of goals and trajectory of illness? The trajectory of illness may be somewhere, but the trajectory of goals may be somewhere else. What is your role is to bring those two trajectories together, where the goals of treatment coincide with the trajectory of illness. And what are the medical versus non-medical goals? Because it's not just the medical treatment, isn't it? People have a life beyond their illness. And what are the things that they want to do in their life? And how your treatment will impact the person's life. So you need to balance both the medical and the non-medical. And is there consistency of goal between the patient and the family member? So these are some of the things you should know before you start. And as I said, ensure readiness. Is the patient and family ready to discuss the goal? Are you able to balance the truth versus hope? Are you able to address benefit versus burden? So many times we try to follow the path of least resistance. They have asked, we are going to provide something. But are we able to balance that? Are we able to discuss the meaning of intervention versus non-intervention? And are we able to continue treatment without abandoning? This is the most important thing. So many times what we see is, okay, if you're not receiving treatment here, you need not come next day, or you can go to another person. So that is abandoning. So are you able to still continue treatment? You had that therapeutic relationship for 2 or 3 years. Recently, I was speaking to one of the pediatric oncologists when I was doing one of the studies. And so I asked him a question. What do you think about referring a child with cancer to palliative care? So he's a medical pediatric oncologist, and he said, surgical oncology is one night stand, and radiation oncology is 1 month affairs, and medical oncology is years of marriage, and it's like divorcing you, means referring to palliative care. So it was a very witty answer, but this is the perception they feel. And remember, patients feel the same thing. Lot of time patients who, when they come to palliative care, they really miss their doctors because they have that attachment. So able to continue treatment without abandonment is also a very important aspect in goals of care discussion. the language of communication. How do we communicate? Like so many times we say, do you want everything to be positive? Do you agree to discontinue care? We will refrain from extraordinary measures. Instead of that, if you change the language and say, we will enable your patient to live as long as possible. So many times patients ask me, can't we do this treatment? Why can't we do this treatment? So my answer is always says, yes, we can do this treatment. However, it is not going to help your patient. I will never say, no, you cannot do this patient. It's the language what you use. I always say, yes, we can certainly do this treatment. However, it's not going to help your patient. So the language that we use. So I will always refrain from telling that I will not do this thing. I will always say, let us do this thing, because these things are going to help the patient. So how you use that language is also very important. So what are the 7 steps of communicating goals of care? The first is creating the right setting. You cannot discuss this in a corridor. It has to be in a room, this more private. Find out what the patient and family already knows, and find out what they want to know. Explore what they are expecting, because that is very important. Trajectory of goals, trajectory of illness. Always suggest realistic goals, and always have empathy. I can see that how you're feeling, or you can always express empathy during communication, and always make a plan. So communication when goals of care change. So I use what is called as an 8-step method while communicating while goals of care change. The first step in communicating while goals of care change is to talk about cessation of disease modifying treatment. So always we start with a recap, talking about what all has happened. Appraisal, what is happening currently. Discussing the refractory nature of illness and discussing why we are having this meeting now. Discussing the benefit versus the burden, and not stopping there and telling, yes, cure is not possible, control is not possible, comfort is possible, alternate, and always having a very realistic hope, providing a realistic information, realistic hope. So it's the first step, is talking about disease modifying, cessation of disease modifying. The second step is the transition of care. You are transiting from one to another. So how do you transit from one to another? So lot of times this is what we get this is a classical thing I used to hear in Tata Memorial Hospital is our room was room number 75. So they say that, see, nothing can be done for the patient, you can go to room number 75. The communication is very powerful. So if you say nothing can be done, then why do you send here in the first place, isn't it? So lot of time people have this misconception. So that's why we always talk about an integrated model of palliative care, where palliative care starts early, journeys along the patient, along with curative or treatment directed towards control. So this transition becomes smooth, not an abrupt thing. So again, I talk about non-abandonment. So I always tell my oncologists, please be involved in the patient's care. You may not be contributing much, but patients knowing that their oncologist is still in charge makes a huge difference for that patient. And always talking about what is the scope of service and clarifying the myths and misconceptions. The third thing is prognostication. It's a very important part of goals of care discussion is prognostication. So what is prognostication? It's foreseeing and foretelling. So foreseeing is the ability to see till the end and what could possibly happen, and communicating that. And lot of time people come and ask us how long question, how long my patient has got, or patients may ask you how long I have got. So how do you communicate that in that context without breaking hope is also very important. I'm not going into the specifics because due to the constraints of time I will not be able to complete it. The fourth aspect is future symptoms. People are all worried about what is going to happen in the future. People come and ask, So, doctor, I am not afraid of dying, but I am afraid of dying in pain. Patients with lung cancer say that I don't want to choke and die. So when they ask, in especially in Hindi, they say, Doctor Sahab, आगे क्या होगा? What will happen in the future? So this is the classical question. So what is the answer that they are expecting? They are not expecting you to tell what all will happen in the future. They are expecting reassurance from. So my standard response is, whatever happens in the future, we will make sure that you are free of symptoms. If you are not free of symptoms, at least we will make sure that you are not aware of the symptoms. So first I am talking about managing symptoms. The second part I am talking about sedating the patient who have got refractory symptoms. So that is very important. That reassurance is there. I worked with one doctor called Dr. Shekhar Patil in Bangalore, who is an extremely busy medical oncologist. And one of the patients said that when I die, I want you by my side. And the Dr. Shekhar Patil made that visit in the middle of the night for that patient and was there when the patient. And that is the reassurance what they are saying. I'm not telling it's practically possible, but when they talk about future symptom, it is the reassurance, not the symptom management. The fifth one is advanced care planning. So when we talk about advanced care planning, people all want to plan ahead, where they want to be when the last days of their life come, what kind of treatment they would like to receive, what should be the medical treatment. You all must have watched a movie called Bucket List, Morgan Freeman. It's a movie. It's a wonderful movie which basically talks about living the life to the fullest. They're both of them patients with cancer, and non-medical goals are as important as medical goals. In TMH, when I had a patient, a 32-year-old dentist with metastatic breast cancer, and her main aim was that she wants to go to Leh Ladakh before she dies, and she had brain meds, she was on O2, and we were very worried that she goes there and she becomes more hypoxic. But that was her important non-medical goal, and we facilitated it. And soon after she came from Leh Ladakh, the next day she got admitted, and in a couple of days she was no more. But that was very important for that person. So that advanced care plan is very, very important. Talking about life-sustaining treatment. So as I said, a lot of time the question gets asked, do you want to do everything or do you want nothing at all? Probably the right way of approaching is to talking to them about what does it mean to have that life-sustaining intervention. What would be the possible outcome? What would be the benefit? What would be the suffering or burden that person has to go? And you need to understand within the context whether we are talking in a medically futile condition, whether we are consistent with the ethics of it, the legal aspects of it, and documenting it. So again, this is a very important aspect of continuing the goals of care discussion. And then we deal with certain specific situations. It could be denial. People will sometimes say, no, I don't believe that the disease has progressed. There could be collusion, where the family member would say, don't send anything to my patient. Anything, information is there, communicate with me or with the family member. There would be conflict. One brother wants one treatment for the dad, another brother wants a different treatment, and unrealistic expectation. These are the very common specific situations that you deal, and you need to have the skills for communication within this situation. And the last part is the terminal phase. Within the terminal phase, you still have to do the goals of care discussion. What to expect? Patients are not conscious, they have a gurgling sound, they get restless, or they are not eating and drinking. What does it mean? All of them, and how this entire thing would evolve. In way back 10 years back, when we were working in HCG, there was a patient, and we said that the patient was almost gasping, and we said that maybe a couple of days to the family. The members were all from United States, and nearly 10 days she remained in that phase, and the family continued to ask us and tell us, doctor, you told 2 days this person will die, but she's still continuing to live. So sometimes we burn fingers, and now I always say this could be what can be expected. However, it could be much longer or it could be much shorter. So it's again a very important thing. So a lot of challenges that comes across is, one, lot of time we fail to discuss the expectation. Sometimes we are what the doctors are called as compulsive doers. We always want to do something, from being there to compulsive doers, and sometimes we try to offer interventions that are not warranted or that's not going to help. And sometimes problem oriented approach and setting the goals actually are different, but we try to uh, put it together. And the language is the most important thing, especially telling, don't worry, everything will be alright, सब कुछ ठीक हो जाएगा, isn't it? Of course the person has to worry because it's such a critical illness and everything is not going to get. So we are setting up unrealistic expectations by using them, offering the false sense of hope and excessively optimistic estimate. This is some of the challenges. And why it is difficult to communicate. A lot of times doctors find it very difficult to communicate. Most of the time that comes from within. You start feeling that sense of helplessness. When I talk to a lot of pediatric oncologists, and they feel really bad when they want to refer a child to palliative care. They feel that they have failed the child or they failed the family. That's a lot of time it's coming within. One's own fear regarding the process of death and dying. I had a patient recently I looked after, which was referred from ICU, and the patient's son was a neurosurgeon, and patient was on a non-invasive ventilator, and she has an extensive metastatic disease, sarcoma tumor of the thigh going into the lungs and the brain, and we were talking to him about not intubating. So he said that as a neurosurgeon, he will never allow any patient to die on his watch. That was his principle. Even when he was a registrar, even his head of the department used to say, now we have to extubate this patient is not getting better. He said that I will never do that. I will give it to another person to do that. So a lot of things are coming from our own fear, but we were successful in that family. We didn't intubate it, but it took us 30 family meetings. That's a completely different story. But our own fears, lack of time, and sometimes people don't want to do it because what would come out? What would if the family members start crying, or if they feel angry? How to do that? Or do I have the skills to reassure? Do I have the skills to provide empathy? And am I destroying the hope of the person? So a lot of things, the challenges are coming from within of ourselves.